right, good morning everyone. We'll start our third day of our conference here with a scientific session. The abstracts, we'll have 3 sessions with about 4 to 5 abstracts each, and then at the end of each session we'll have time for Q&A. Please keep your presentation around 4 to 5 minutes to ensure we have adequate time for discussion. Our first paper is from Dr. Rahul Samtani, and you here? Okay, please step up.
All right, can you guys hear me? Perfect. All right, my paper it's called The Spine Surgeon Social Dilemma, the Benefits and Risk of Social Media Use in the 21st Century. It was published at a UCSF in 2021 in the Global Spine Journal. Disclosures none. So the background of this paper, essentially social media and online presence can be used for various aspects of your medical practice. It can help you market yourself, enhance patient education, complement offline information, and strengthen your relationship with patients. But of course, there's always risk associated with social media use. So the objectives was to document the social media presence of a broad spectrum of spine surgeons across the U.S. in both private practice and academic centers. We got 325 spine surgeons across 76 institutions. We performed a search on the spine database, the NAS database. We identified the demographics of these surgeons, and we investigated how much they used their social media, whether they had a social media presence, whether they had a personal website. And then we defined whether they were active or passive, and that was defined as the number of posts per month, what type of posts they were, whether they were text or images or different information regarding spine surgery. Of the results, 325 surgeons, 96% were male. The average age was about 51 years old. Over half of them had a LinkedIn, and about 18% had a professional Facebook, but of the other social media websites, only 16% had other platforms. So the main thing, the surgeon's age, the years in practice, and the practice type were strongly correlated with social media activity. So on this graph, you can see that in terms of any social media posting, majority of practicing surgeons, 60%, over 60% had no social media posts at all. And if they were to post, it was usually on Facebook or Twitter, and it was about once per month. And here you can see that private practice and younger surgeons were more likely to be using social media in their practice. And our findings suggest that there's an underutilization of social media in private practice, in spine surgery in general. And why it's important is the internet is essentially an open source information. So people can publish anything they want online whenever they want. And so there's a lack of credibility and a lack of good information online. So there were different studies. There was one study about FAI that was looking at YouTube videos on FAI, and 19% of the videos were found to have no usefulness, with 54% found to have somewhat usefulness. In spine surgery specific, there was videos on discectomies, 81 videos, only 16 were rated as good, with the bulk of them rated as poor or inadequate. And then another one, 1/3 of the sites were rated good, with, again, the bulk of them rated inadequate. So why that's important is because as surgeons, patients come to you and they have already looked stuff up online. And if the things they're looking up online is poor information, then that causes you to have to either correct that or be fighting a losing battle. The best thing you can do and how you can make it better is you can have an online presence, and on your online presence you can direct them to a static website, which is your website, where you can educate patients so they can get high quality information, and they can start to understand what correct medical information is. Because what we're seeing is a lot of times, I'm sure you guys are seeing in your practice, or patients are coming in and they're saying, I watched so-and-so video, and this is what they said, and then you're fighting that losing battle. So in a recent study in the hand literature, actually, physicians with personal websites received higher health grade scores. And it may seem daunting at first to have an online presence, but it's manageable if you have a practice coordinator or someone that can help you assist in this. The steps that you can do to start this process, if this is something you're interested in, is to create a static website with information, videos, stuff that patients can look up, and then have your social media post kind of link people to that website to help educate them. And that can actively engage patients in their care and actively make them feel like they're more connected to you and their community. That's all I have. Thank you.
Good morning, everyone. It is my pleasure to present an abstract on next-generation genetic sequencing of malignant peripheral nerve sheath tumors, a 5-year institutional experience. So we'll start off with MPNSTs. They're rare and aggressive soft tissue sarcoma that carry a poor prognosis. And the 5-year survival rate ranges anywhere from 20 years, or from 5-year survival rate ranges from 20% to 50%. We describe our single center case series of surgical resection of MPNSTs and the genetic and molecular characteristics of which have not been well described in conjunction with patient's clinical course. So we aim to utilize next-generation sequencing in conjunction with clinical outcomes to understand the presentation, course, and genetic underpinnings of MPNSTs. To do this, we took patients that underwent surgical resection of MPNSTs at a tertiary center within the last 5 years, and we reviewed them for their genetic evaluation with UCSF 500 next-generation sequencing, alongside their clinical, surgical, molecular, and postoperative variables. The first thing we see when we look at the baseline characteristics of these patients is that we have 10 patients, of which 4 are female, with a mean age of 38 years, and they underwent resection of MPNSTs. Of these, 7 had a diagnosis of neurofibromatosis type 1, and this is fairly close to what we'd expect given roughly equal prevalence between men and women, as well as it being more common in those with neurofibromatosis type 1, but not exclusive to them. When we look at the tumor characteristics, we can see that tumors were most commonly located in the cervical spine. We had 4 patients, and then next it was lower extremities. We also had a scattering of localization in the scapular area, submandibular, or suboccipital areas. And the most common presenting symptoms in the spine were neuropathy, oftentimes pain, numbness, and extraspinal. It was most commonly a mass of notable growth or tenderness. And I think what one can appreciate is that when a tumor is rare and can have various presentations, it can be difficult to spot. Now, when we look at the tumor identity, these tumors underwent histology as well as next-generation sequencing. On histology, the tumors showed positive staining for S100, SOX10, and H3K27ME3, and these are used to distinguish MPNSTs from other tumors with various lineages, with SOX10 being a marker for cells of neural crest origin and S100 being a Schwann cell marker. What you can appreciate here is that there's no consistent, there's not necessarily a consistent staining pattern for every single tumor. So you can't just order a panel of immunostaining and then diagnose it as MPNST. So using the UCSF 500 next generation sequencing, we're able to see that the most frequent mutations were in NF1, CDKN2AB, SUS12, and TP53. And we also had some other markers that were implicated in as tumor suppressor genes as well as for telomere function that aren't listed here. Now for patient outcomes, what we saw is we had recurrence in 7 patients. 7 patients underwent adjuvant chemotherapy with 6 undergoing radiation therapy. And a total of 3 patients died with a mean survival of 1.1 years. And for the surviving 7 patients, the median follow-up time was 1.7 years. Additionally, the median cohort KPS did not change from 80 preoperatively. So pretty much this is one of the larger case series of MPNSTs incorporating surgical, clinical, and molecular characteristics. And although we saw classical and some novel genetic alterations, the tumors were too heterogeneous to correlate specific genes with survival. But regardless, understanding the presentation and genetic patterns is essential for prompt diagnosis and treatment of a rare tumor like this. Thank you.
Good morning. I'm Dr. Shun from South Korea. Today, I prepared the presentations about image generations using generative AI with a very more cheaper images. I'd like to get expensive images. If you are young age persons, maybe you used one of these tools from text to making images. Van Gogh didn't draw this work, but we can make the work using the sketchy images. This work is based on the generative AI. One of the famous generative AI algorithms is the GANs. GANs composed of the two structures. One is the generators, trying to make a fake image similar to the real one, and the other one is discriminators who try to distinguish between the real and the fake one. And after the several times of the trainings, generators can make very similar fake images. GANs are composed of the roughly unconditional and conditional GANs. Conditional means when you make the human faces, we can control the length of the hair or the shape of the nose or the shape of the mouth. In this project, I used the Pix, one of the conditional GANs. The last figures of the bags can show the characteristics and the function of the Pix. We serve the sketchy or the structural images as an input, and then the algorithm can add the color. In the medical field, two algorithms can be used to generate the medical images, but in the view of the white box in AI, Pix is more proper. My project is recently released in the Spine Journal. I used two paired images. One is the MRI, and the other one is the simultaneous fusion PET MRIs. The PET is very good for detecting the metabolic status of the bone marrows for the infection and tumor. In this project, I used more than 2,000 images and two algorithms, Pix and DDPM. DDPM is such as the diffusion models. And I measured the similarity of the images between fake and the real one, PSNR, SSIM. This figure shows the overall the project. I tried to train the algorithm with the paired two images left side, and then I only served the MRI images, and then the algorithm can make the fake PET images, and the discriminators can compare and calculate the error between the real and the fake ones. You can see from the left to the right, the fake images become similar to the real ones. This is the result. Right bottoms, SSIMs, in the case of SSIMs, we obtained more than 0.9. SSIM shows the more the visual perceptions of humans than the PSNR. PSNR just calculate the similarities in physics. This is the examples of the generated images. The bottom is the real one, and yes, real one and synthetic ones, very, very similar images. It also shows the another examples. And between three surgeons try to differentiate the real and the fake ones. They show the accuracy is 50%. And in the view of the external validations, I tried to these algorithms to detecting there is infection or not. In the case of the ankylosing spondylitis, it shows relatively very low FDG uptakes typical from the infection. And in the embotic type 1, it also shows a very low level of the FDG uptake. With the confidence for making these fusion PET MRIs, nowadays I'm trying to make the contrast images based on the non-contrast images. The right side is the real one, and left side is middle is the synthetic ones. The real one has the very artifact because it obtained from the 1.5 Tesla MRIs, and based on the synthetic one, we remove the artifact and a very high resolution images. To be accepted as the real techniques in the medical field, I think there is so many barriers I have to overcome. But I guess considering the rapid of the AI technology developments, this theory may be realized in the future. Thank you.
Great. My name's Tom Wozniak. Good morning. I'm one of the PGY7 neurosurgery residents at UCSF. And this morning I'll be talking about some work conducted under the direction of Dr. Chris Ames, trying to cross-validate body composition assessments performed using a bioelectric impedance testing. No disclosures relevant to this talk. And by way of background, briefly, so there's growing evidence that suggests frailty significantly impacts outcomes among patients undergoing adult spinal deformity surgery. Body composition assessments specifically stand to efficiently capture multiple dimensions of frailty and allow us to potentially infer some aspects of physiologic reserve to get at whether or not patients can safely withstand and ultimately successfully recover from deformity surgery. And as yet, there is no gold standard for doing these body composition assessments. There's multiple techniques, but nothing's really risen or proven itself to be the best. One such technique is actually data being collected by Dr. Ames in clinic, both preoperatively and longitudinally. And it's this in-body device, which goes beyond really just measuring a patient's height and weight, but by placing your hands on these conductive pads and feet on conductive pads, imperceptibly low electrical test pulses are conducted and try to give an assessment of a patient's body composition. And a couple of variables that it puts out to you. This is an actual patient report on the right, all these different dimensions of body composition. These three in particular, the skeletal muscle mass, the percent body fat, and the visceral fat, are all body composition variables that have shown to be relevant in a lot of different disease states. And so we wanted to take a deeper look and really ask the question, are these outputs that this in-body device gives us, are they even remotely accurate or reflective of reality? The way we went about trying to assess that was leveraging pre-existing CT scans in people's charts. And we went through and scrubbed all the CT scans for anyone who had pre-op in-body testing. And we put those CT scans through really what is the latest version of a UNet-based neural engine to do automated per voxel tissue segmentation to identify the actual number of voxels that belonged to either visceral fat, subcutaneous fat, or skeletal muscle. And so the data sources, we ultimately identified 99 patients with adequate in-body and pre-op CT scans that included the trunk and some aspect of the spine. The CT scan, which was closest, since many patients have multiple CT scans in their chart, was closest in time to the in-body testing, was used for further analysis. And it worked out that about 91% of patients had a CT performed within 1 year of their in-body testing. Most of the CT scans, almost 70%, were just regular CT lumbar spine scans, but there was a smattering across the board from abdomen, pelvis, whole body, PET CTs, CT, T and L spines, but we used really whatever we had. And looking at those scans, there's about an 11-liter volume of kind of trunk that tended to be, on average, imaged. And so here you can see, again, an actual patient in-body output. And this is that same patient's CT, chest, abdomen, pelvis, with different colors labeling identities of voxels, green being sub-Q fat, yellow being visceral fat, and red being muscle. So we went through every single CT scan to assess and make sure that the AI segmentations were accurate. And once we had adequate data quality, we just did the simplest thing, and we correlated the two. And so looking at 3 different graphs here, the top left being the correlation between the in-body percent body fat and the CT-derived percent body fat. It's actually an extremely significant and pretty tight correlation. You get a similarly significant correlation, but not quite as tight for other dimensions. So visceral fat and skeletal muscle mass. But again, they're all significant. And the conclusions we drew from that was that it's actually, I think, something encouraging because we're just taking available CT scans with a relatively limited window, most of which are lumbar spines. And so we wouldn't necessarily expect kind of a one-to-one relationship with the in-body data, but it's actually quite close. And so potential confounds would really be just trying to get more coverage of CT scans. And then, of course, people's body composition can change over time. And so some patients, it was about a year delay between the 2 testing. Where we want to go in the future is we're actually in the process of developing an algorithm to create what is really a 4-dimensional CT mosaic of patients. So, X, Y, Z, and time to see how body composition changes over time, and running it through the latest generation of this algorithm, which actually allows us to do tissue segmentation. This is an actual scan from the same patient I showed you earlier, now doing a per tissue, per bone segmentation. And then we can, I think, really drill down even beyond things like global body composition and look at, say, for example, erector spinae volume, erector spinae muscle quality, the UIV, bone density, and really try to create some hopefully compelling prognostic models. And with that, I would just like to thank Dr. Ames, the rest of the team, our patients, and the clinic staff. Thank you.
Good morning. This abstract is about a multi-center trial that we looked at subjects for mild radicular symptoms with degenerative discs at 3 continuous levels that required anterior cervical spine surgery and were randomized to anterior posterior decompression and fusion with a percutaneous posterior instrumentation, which is also known as DTRAX or CAVIX. Subjects were excluded for prior surgical intervention at any of the indicated levels or baseline neck disability index less than 15/50. We looked at radiographic fusion for this portion of the study, changes in NDI, incidence of subsequent surgical interventions, and change in neurologic assessment. The primary endpoint was radiographic fusion at 12 months, and the secondary endpoint was safety composite based on radiographic fusion, improvement in NDI, absence of subsequent intervention at the index level, and decline in neurologic function. Radiographic fusion was assessed with X-rays and CT scan data and was evaluated to see if there was any dynamic instability of greater than 2 degrees of motion and evidence of bridging bone seen on CT scan. Successful improvement of NDI was defined as a 15% or better increase in the improvement from baseline. And change in neurologic status was assessed by independent clinical events committee of spine surgeons that were blinded to treatment. Total of 227 subjects were enrolled with 57% female, and 176 subjects were contributed to our 12-month outcomes, and 113 subjects contributed to our 24-month outcomes. At 12 months, the circumferential arm exhibited superior data in terms of radiographic fusion when compared to ACDF, especially on CT scan. And at 24 months, this was maintained. The observed differences were largely driven by differences in rates of revision of ACDF, which was then converted to circumferential fusion if they did not fuse at the 12-month mark based on CT data and patient complaints. So The findings from this study at this point show reduced reoperation rates when doing anterior and posterior augmentation and superior safety outcomes. The fusion rates were improved as evidenced by CT data and X-ray data. In terms of bridging bone, the CT data was a bit more aggressive in terms of defining fusion as compared to range of motion data, as we know from our clinical practice. And the composite safety demonstrated that there was no increase in adverse effects. Thank you.
All right, we'll take some questions. Maybe I'll start off since Dr. Shah's up there. So great study, and it's definitely a issue that's very relevant to a lot of our practice. We looked at our institutional data with 3-level ACDFs, and it seems like with the levels they fuse at different times, right?
Correct.
What end up being is that the middle level fuses fastest, followed by the top, and bottom level seems always drag behind it. At 1 year, it's probably like 20-30% patients fuse the bottom level. The other 2 levels fuses much higher, like 80-90%. So in this study, I think the 12-month sort of cutoff, how are you sort of defining the pseudoarthrosis? Any one level, or would you treat, and then if they crossed over, do you just do one level, or you do all of them?
For the posterior augmentation?
Yeah.
Posterior augmentation is only at the level that was pseudoed. And so, and I think your observations are correct. Now, there's a couple of portions of the study that have to be sort of drilled into to really answer that question. First of all, we used allograft only. So everybody was used a dynamic plate anteriorly and allograft only for the inside. Now, many of us use additional augmentation devices, or we use metal or things of that nature. This was only allograft for the inner body spaces. Posteriorly also, there was no that crest or any other bone marrow aspirate. It was all autographed along with the posterior cervical cage. But your answer, your assessment is correct that we did see different levels of pseudoarthrosis for folks, but it was not just one level for most of the conversions. Many people that did convert to the 3-level posteriorly or 2 levels posteriorly. And there were still some people that had anterior and posterior intervention and still had pseudoarthrosis.
And also, not all pseudos are symptomatic. I would say probably a third of them are symptomatic, and the others don't. So a lot of times we follow them. Just if it becomes an issue, you fix it. If not, just leave it be.
Exactly, and so that was the crossover. So the design of the study was to have people randomized either having anterior, posterior, or having the option of changing arms at the 12-month mark. And so people were given that option. If they chose not to have the surgery, they were not forced to.
Thank you.
Maybe, thanks to all the authors for contributing to the session. And maybe I'll start with a question to Rahul. Welcome back. And I remember when you proposed and we were working on this paper, I had really no idea what it was about. I get a better idea now. And I wonder, you reported the prevalence of use of social media by surgeons, but what's the outcome metric? And what I mean by that is are we looking at an increase in the number of referrals, increase the number of surgical cases that come from this? So what is the output that we're really looking for? And as you're getting the microphone, I'll just say sort of my criticism of social media, like Lori's done a good job of putting some things on all of our LinkedIn accounts, but my criticism is I really don't want to reach general audience. All my referrals come from a surgeon. And so I'm not really interested in having a presence for a general audience. But I'm interested in how you measure the outcome of social media presence.
So one thing that, can you guys hear me? One thing that we noticed is that for private practice, it's a little bit more important. I don't have the UCSF name tied to my practice, so I have to reach out to patients and I have to recruit them. So, I want patients to just walk off the street and see me, because that's how my practice goes. That's how I get a patient referral base. And, obviously that doesn't necessarily apply to the academic practices. So that makes sense for you to not want that, but for me, it's a little different. In terms of outcomes, I think that would be the next step of the study. For me, I have a personal website, and I get probably at least 3 or 4 people reaching out directly to me from the website, and about 2 or 3 of those translate to cases per month. So that, for me, it is just anecdotal, obviously, but that for me, and I know for, I don't know if you remember Mike Venezia, he also has a website as well, and he does the same thing, and he gets a decent amount of patients from that because he, again, is in true private practice where we don't necessarily have a university name tied to our practice. But I think the outcomes and seeing how the patients are funneling into your practice, that would probably be the next stage of this study. All right.
Yeah, I think, just as a comment to that, I think that it's much more important for the people in private practice. However, the institution, at least our institution, is extremely interested in social media and how people rate you. And all these ratings, whether it's from Yelp, Google, et cetera, they all come back as a score for you. And whether you like it or not, it's unfortunately the state of the current state right now, and whether it's true or not is up to argument sometimes, right? So, but I have a question for Dr. Wozni. You talked about there. You talked about frailty, yet I only see images. So frailty is kind of a health status, depending, that determined by your functionality and also comorbidities. How do you correlate somebody's visceral fat and total body fat and how their bones look to how they're actually functioning? Because I'm sure there's a lot of people that look like that on the CT scan, but might be functioning exceptionally well. And there are people with no visceral fat that might be extremely frail and not functional at all.
You're absolutely correct. I think body composition is only one dimension of trying to get at a much larger concept of frailty, and looking at it coarsely with just like compartments of tissue is really only the start and probably one piece of many complementary pieces of information. What doesn't fit into that 5-minute talk, or I think some of the early findings we're seeing actually looking at, say, particular muscle groups and those actually being helpful in predicting people's alignment after surgery. And so they're also seeing early signals of people's failure rates being associated with muscle quality, right? And so fatty infiltration is inferred by imaging. And so, yeah, the by no means does it capture all of frailty, but hopefully some things to try to get a sense at maybe what functional reserves a patient might have, short of doing like cardiac testing and so on and so forth.
The other question is, where's the machine stuff?
So this is public, freely available software that a research group out of the EU is making available. It's getting better every month. The main limitation to its use actually is it's extremely computationally intensive. So if you were to try to run that algorithm on your laptop, it would probably take about 2 hours for a chest, abdomen, pelvis. But we're running it on an NVIDIA GPU, which, I mean, I hope everyone bought their NVIDIA stock a year ago. But it's really fantastic in accelerating the actual segmentation. And so we have these segmentations that took an hour on my laptop running in about 30 seconds now. So I would be happy to set anyone up with the software. It's free.
All the fellows get the best stock tips a year late. So in the interest of everybody getting questioned, for Dr. Yamada, a really elegant study on genomics. What about proteomics? Where's Dr. Yamada? What about proteomics as well? So you're looking at the genomics, you weren't able to really show in a small series a correlation. But what about expression and protein expression? Is there a big difference there? And might that be something that might be more sensitive to outcome?
Yeah, thank you for your question, Dr. Bervin. So proteomics, the current UCSF 500 data looks at just like those panels of genes and like looking for mutations that might exist, like common mutants. I would be interested in proteomics actually, but we don't currently have that data. It would have to be something that we would have to send out as well. But that's a very good point about looking at it from other angles.
Final question, Dr. Zhang. Great talk. I must say I was a little bit overwhelmed with all the data. And almost you need like AI to look at the data, right? But I'm trying to figure out what the relevance of the imaging is with your techniques versus what we currently do that generally tend to work very well, which is look at the imaging, get some lab tests, especially for spondylodiscitis. So can you clarify that for me and what your ultimate goal is? Is it to have one imaging type that allows you to diagnose everything? That's one part of the question. The other part of the question is there are a subset of people who have what we call discogenic back pain that have probably low-grade infections. Does this technology allow you to assess those patients and identify those patients and distinguish them from people who have just mechanical low back pain from degenerative disc disease?
Yeah, thank you. Good questions. It's very difficult questions. For the first questions, there are so many techniques to generate images. And for example, transformer, you may be heard about the GPT. GPT contains the transformer technology, but I didn't use that kind of the algorithm because it's just based on the not real data. So I used the pix-to-pix for the real paired data. So it's kind of the translations, not generation. Translate from the MRI to PET MRI, or the recent studies from the non-contrast to contrast based on the training. So I needed to focus on or the stress on the how we can use the data more reliable with the reliability or the white box, not black box, to use in the medical field. And the second question is the mechanical pain or the back pain, how to differentiate back pain. It's very difficult problems. We need more the proper data to analyze. Garbage in, garbage out. Maybe you heard about this. We don't know what kind of data is proper to find out, to differentiate the kind of the back pain. So I think the PT data or the other nuclear data is maybe proper, I think, but it costs a lot of money to obtain the input data to analyze. And also, not just the images, we need to use the multimodal data like the NDI or something else. But it also can be contained by the human, by us. Yeah, so I guess it can be possible in the future soon. Yeah, thank you.
Thank you. We'll start the second session with Dr. Umar Jawad.
Hi, good morning. I'll be talking about, my name is Umar Jawad, and thank you for the opportunity. I'll be talking about disparities in utilization of motion-sparing technology in cervical spine. I'm a PGY3 resident at University of Arizona. So I have no relevant conflicts of interest to this talk, and my co-authors include Dr. Kasana, Dr. Greenstein, Dr. McDonald, and the senior author is Dr. Chutkin. So the gold standard for degenerative disc disease was historically the discectomy and motion-sacrificing fusion surgery. This treatment strategy provided predictable relief in cervical disc degenerative disease. However, increased motion adjacent to the fused segment led to increased interdiscal pressure, which basically attributed to the development of adjacent segment disease. This was a landmark paper by Dr. Hillebrand. It reported adjacent segment disease in 1/4 of all patients undergoing ACDF at 10 years at a rate of approximately 2.9% per patient per year. And they also found accelerated degeneration seen at C5 and C6. That led to development of motion sparing technology in spine, and cervical disc replacement was designed to retain and preserve motion in an attempt to reduce the rate of adjacent segment disease. Long-term studies have shown a lower rate of adjacent segment disease requiring reoperation with cervical disc arthroplasty. Sasso et al. Did a prospective trial with 47 patients with ACDF and 47 patients with cervical disc arthroplasty. And 7 and 10-year standard outcome scores were better in CDA group as compared to ACDF group. Similarly, Garnett et al. Did a multi-center prospective randomized control trial to adjacent segments, cervical disc arthroplasty versus ACDF, and statistically superior for overall success for CDA with 80.4% versus 62.2% for ACDF. So with this background, now talking a little bit about what the disparities are. So U.S. Department of Health and Human Services has defined social determinants of health as conditions in the environment where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health can be grouped into 5 domains. These include economic instability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. Social determinants of health also contribute to health disparities and inequities in healthcare access and outcomes. And then, what exactly is a disparity research? So, National Institute on Minority Health and Health Disparities have defined the focus of health disparity research to encompass health differences in socially disadvantaged population and specific outcomes, including higher mortality rate, increased global burden, higher incidence or prevalence, higher mortality rate, increased global burden of disease, poorer health behaviors, and clinical outcomes related to the previous outcomes and worse outcomes on validated and specific patient-reported outcome measures. So there have been a few studies that have been done looking at my research topic, exploring the disparities in motion-sparing surgery in spine, in cervical spine. And one of them was done by Sefi et al., but looked at the national inpatient database, and they found age-related, insurance-related, and higher length of stay for ACDF. However, there was increased revision burden with cervical disc arthroplasty. A similar study was done by Gauze et al., showing it was also done from the National Inpatient Database, younger and healthier and higher socioeconomic status patients undergoing cervical disc arthroplasty as compared to ACDF. And lastly, Wick et al. Did a study showing racial disparities in resource utilization, length of stay, and readmission rates, whereas ethnic disparities and complications. So what I did was that we took a NISQIP database from 2010 and 2021. We used the CPT codes for cervical disc arthroplasty and ACDF and to isolate the cases. And then we used preoperative clinical, racial, and gender data using the NISQIP data. In addition, we used Pearl Diver database from 2010 to 2022 for area-level family income, education, insurance status, and unemployment. These 2 databases are not connected, so these 2 analyses were performed separately. The data by no means is connected to each other. We used chi-square, Kruskal-Wallis, and logistic regression for univariate, categorical, continuous, and multivariable analysis, respectively. So our results showed that we had approximately 5,912 cases of cervical disc arthroplasty in a NISQIP database and 32,625 cases of cervical disc arthroplasty in the Pearl Diver data. And just for the sake of time, I will just be presenting the multivariate analysis. So this is the multivariate analysis of NISQIP data, and it showed younger age, male gender, and Asian Pacific race and elective surgery were associated with undergoing cervical disc arthroplasty in NISQIP database. The presence of type 1 diabetes, smoking, and hypertension were associated with undergoing ACDF in the NISQIP database. And for the Pearl Diver data, it showed younger age, higher area-level family income, and higher mean percent of patients with private health insurance were associated with undergoing cervical disc arthroplasty. Higher area-level unemployment was associated with undergoing ACDF. So in conclusion, there are unique sets of racial, ethnic, gender, and socioeconomic disparities for cervical and lumbar spine motion preserving surgical techniques. Disparities are dynamic and complicated, and they keep changing with time. The biggest limitation of my data is that the two databases were not connected, and there was a lack of competing analysis that could be done between the racial, gender, and ethnic disparities and the socioeconomic disparities. However, it's a limitation of the data, and that's all that I had available. And to my knowledge, this is the largest analysis of the contributing factors. Thank you.
Next up is Dr. Zhang.
Good morning, everyone. Today, I'm here to present our study about incidence and risk factors for delayed expansion and severe dysphagia after single-stage circumferential cervical spine surgery. Let's begin introduction. Delayed expansion and severe dysphagia are two well-recognized complications after single-stage CCSS. Our study aims to identify the incidence and risk factors for these complications. We conducted a retrospective review, time spanning from April 2018 to June 2024, and all surgeries were performed by a single surgeon. We defined delayed expansion as expansion on the second day or later after surgery, and defined severe dysphagia as the patient is unable to tolerate regular or soft diet after surgery. And we include the patients who aged about 18 years old and exclude patients intubated before surgery and who have severe dysphagia or neurological disorders, preventing expansion and intake after surgery. A total of 50 patients was included in our study, and there were 30 males with average age of 22.5 years. We found that the average LS was 8.5 days, with an average ICU stay of 2.3 days. SD was observed in 14 cases, and D was observed in 8 cases. And SD significantly increased ICU and LS. The result of logistic regression shows that surgical duration was an independent risk factor for DE. And the extent of cervical lordosis correction and the time to expute was risk factors for SD. Here is a typical case of our study, a 59 years old female patient with anterior from C3 to C7 and posterior from C2 to T2 surgery. Including most of patients may be severely extubated at the same day of surgery and can tolerate a regular diet. And the surgical duration is a significant risk factor for delayed expansion. And the extent of cervical lordosis correction and the time to expute are risk factors for severe dysphagia. Severe dysphagia is significantly increased both ICU and overall LS. Thank you.
Next up is Dr. Lanjun Guo.
Good morning, everybody. Today, I'm going to share the topic about the impact of position changes on intraoperative neuromonitoring baseline changes during the posterior cervical decompression and fusion. And as everybody knows, the posterior cervical decompression and fusion is a very common way to alleviate the spinal cord and the nerve root compression. At the same time, the neuromonitoring is a very crucial way to monitor the nerve function and to help us avoid the spinal cord injury. And before the incision, we sometimes get the supine baseline and the prone baseline at the same time. But when we compare the two baseline, we found some of the patients may exhibit the change in this baseline. So we found some reports or the publication point out that the position changes may affects the baseline changes. So in order to figure out how position changes to affect the baseline changes, we started our research. During the research, we revealed the patients received the PCDF in our department between the 2016 and December the 2027. And finally, a total of 1,577 patients was included into our study. Among them, about 152 patients with baseline changes. Among these patients, 23 showed SEP changes and 82 showed MEP changes, and 47 showed changes in both SEP and MEP. It was very interesting that we found the most common reason for these baseline changes may be the anesthesia and then the head and neck posture changes, followed by the upper lip compression and technical issues, and the other reasons may include the hemodynamic alterations and the concurrent disease and the unclear etiologies. This is the result we get from the research. The first picture, we can see that here is the proportion about the different types of the evoked potential changes. The biggest proportion we can see is the MEP changes, and then followed by the SEP, followed by both of them. Here we can see the reason for baseline changes, and in a previous publication, it pointed out the neck posture changes may be an important role for the baseline changes. So we did another further analysis about the diagnosis distribution of the neck posture changed patients. Here we can see the most common reason, the most common diagnosis was the cervical stenosis with the cord compression, and then followed by the fracture. The last is the kyphosis. At the same time, we did an analysis about the diagnostic distribution of the patients with baseline changes. It was similar that we can see the cervical stenosis with cord compression is the most common diagnosis, and then followed by the fracture, and then is kyphosis and tumor. From this, we can see maybe in the future we need to pay more attention to about the cervical stenosis with cord compression patients. When we change the position of them, it may cause the baseline changes. So we can conclude that if we get the prone supine position and the prone baseline at the same time, it may help us to guide the optimal position during the PCDF surgeries. And it was also effectively in helping us to predict and analyze and preventing nerve and spinal cord injuries. In the future, we are thinking about to perform multiple center studies and try our best to standardize the intraoperative neuromonitoring techniques and the protocols. Also, we are thinking about to include longitudinal follow-up to evaluate the long-term effects about the baseline changes in patients' health and recovery. Thank you.
Last speaker for this session is Dr. Brandon Ortega.
Good morning, everyone. My name is Brandon Ortega. I'm an ortho spine surgeon out of LA, and today we'll be talking about the utilization of ultrasonic devices for performing posterior column osteotomies in adult and pediatric spine patients. Relevant disclosures for this talk are that I am a consultant for Strykel Neurosurgical, specifically the ultrasonic division Sonopet. The objectives of this talk are to describe our surgical technique for utilizing ultrasonic technology in adult and pediatric patients. Ultrasonic technology it made some advantages in the comparison to traditional surgical techniques such as osteotomes or oscillating burrs. Multiple studies have shown it to be a safe, efficient technique with decreased blood loss and increased bone graft harvest. However, there is limited data on a safe surgical technique, which most likely explains the underutilization of this technology. Our technique for utilizing ultrasonics, which I learned as a fellow at UC Davis by my mentor, Dr. Javedan, involves using it as a surgical blade, essentially cutting and dragging the instrument in one fluid motion across the bone, as opposed to using it like a saw. This will provide tactile feedback to indicate constant contact with the bone. Loss of resistance indicates the completion of that cut. Common pitfalls that we see are losing that tactile feedback, which can lead to obviously a dural or neural root injury. Another common mistake is for people to use it like a saw, like I just mentioned. This is particularly common in first-time users, perhaps because the blade maybe looks like a saw. I'm not sure why, but as far as our steps, we perform our inferior articular process as demonstrated on the model. We perform a gill-type osteotomy going from the pars to the contralateral pars, and then perform our SAP resection as we'll show shortly. Here we can see our inferior articular process resection starting from the pars, using the surgical blade in one fluid motion, maintaining constant contact with the bone. Once we lose that resistance, we know that we have reached the appropriate depth. We then can use an osteotome to complete that cut. We then obviously harvest that bone, and we'll use it for our autograft. And then for the other side, we do the same thing, starting from the lamina, using the blade in one continuous motion, maintaining constant contact with the bone. Once we lose that resistance, we know obviously that we don't need to go any deeper. And so then same thing, osteotome to complete that cut. For the gill-type osteotomy, we remove the spinous process. We go from the pars to the contralateral pars. So as we drag that ultrasonic instrument, we're dragging in one fluid motion. And this is a more sort of stressful cut, especially for new users, because you're cutting directly over the cord or the dura. And so the key thing is to just drag that instrument, follow the contour of the bone. Once you lose that resistance, you don't keep pushing the instrument down, and here you'll see that as I'm dragging the instrument, I feel that last piece of bone. Once I cut through that last piece of bone, I can use the osteotome to complete that cut. And then similarly for our SAP resection, sorry guys. I usually place a Woodson or a Penfield 4 right underneath the SAP, right above the pedicle, protecting our dura and our nerve root. And here we can be a little bit more aggressive because we have that Woodson protecting us. And once again, same thing, maintaining that blade with constant contact with the bone. Once we're through, we can then use that osteotome to complete that cut. And so here, this is a case that I did as a fellow. It was an AS case, and we've completed our inferior articular process resections. Now we're doing our gill-type osteotomies. We did half of one side, I'm doing the other side. And we had the patient in traction, so you can actually see the lamina split because of the traction. And once again, we're cutting, using it like a blade, like a scalpel. Once we complete that cut, you'll actually see the lamina split. And so this is a very safe, very efficient technique that allows us to do these big, complex deformity, both in adult and pediatric patients, by maximizing our efficiency in the OR, maximizing the amount of bone graft that we actually harvest. And I apologize, I don't have a picture of the actual bone graft, but future studies will demonstrate and compare that bone graft harvest with using osteotomes versus a oscillating burr, versus using this technique with ultrasonics. And so here you can see just how much actual autograft we get in kind of en bloc, and then we just pass it off to our back table, and they're able to harvest all that bone. And so this allows us to perform all our osteotomies safely, and as you can see in the thoracic spine, we're cutting directly over the cord, and and this is a technique that once you've kind of demonstrate the steps, it is very easy and reproducible in the OR. So take some take-home points. Once again, use the blade like a scalpel, which is very natural for most surgeons. You're cutting and dragging, maintaining that tactile feedback. Once you lose the resistance, then you know you completed your cut. And once again, avoid using it like a saw. And now, any questions or comments?
I have a quick question.
Yeah.
That looks like a very efficient way of doing PCOs,
Yeah.
for sure, compared to Keratins and whatnot, probably a lot faster too. Have you compared with this technique versus the historical data on the amount of time saved, or EBL or less transfusion and whatnot? Kind of correlate this to clinical.
Yeah, so those studies have
differences?
been done. They've demonstrated increased efficiency in the OR, less blood loss. Our goal, and we're trying to do this with the Shriner database. However, just as most of you guys know, the Shriner's issue with IRB approval is a nightmare. So we're trying to get that done with comparing those techniques in the pediatric data with Shriner's.
Yeah, Lee, that's a great question. So I thought about how to structure that study, and in my mind, the cleanest way would be to an internal control to kind of look at my patients prior and post. The only thing that then we have to correct for is just the general learning curve. Like I was just generally slower and not as efficient my first 5 years in practice compared to my second 5 years. So, I mean, that'll actually improve the data, but that's going to be a confounding factor. So, but I have done studies such as similar to that, setting it up like that with Dave Skaggs, where we looked at, for example, power pedicle screw insertion versus freehand, and then just use the time point, usually like a 6-month gap between conversion to fully to a technique. And I think we could potentially show some decrease in EBL and also increased efficiency with decreased time. One of the data that we don't have, and it would be nice to do, and I thought about this, is to measure the bone graft. To kind of put it in a cup and see how many cc's of bone graft we get. But anecdotally, I could tell you that our harvest of bone graft probably is easily tripled, if not more.
I have a quick question for the third paper, which looked at the changes in terms of pre-op to supine to prone for the cervical cases. Did you have a chance to look at the correlation, if there's any correlation between the number of levels of severe stenosis and or maybe a correlation with myelopathic signs preoperatively? Because we always get the question, should we do pre-fit baselines on these severely stenotic patients? And it's possible that if you have more levels of stenosis, maybe that's where the findings are.
It's a good question. Thanks for your question. And yes, I think different levels of numbers may influence the baseline, but in our research, we didn't include this factor into our the reason for it. But maybe in the future, we will try to figure out it. Actually, we originally our plan was to include like the 10 years data, but now we just finished like 80 years. So it was a difficult and hard work. So maybe in the following analysis, we will take this into consideration. So I think it's a good suggestion, but we're still working on it. Thank you.
I have a question for Dr. Zhang. Oh, great talk. One of the things that really perplexes me is how you can actually say delayed extubation, how you can use that as a measure, because it's so variable. And it's variable because anesthesiologists determine whether they want to extubate the patient or not, whether you have the patient as a second case and they end up late, on a Friday and they don't want to extubate the patient because they aren't comfortable extubating the patient, and they don't want to extubate the patient in the ICU because they think that the patient, they don't have any real criteria. They do a cuff leak test or something like that. But a lot of patients, I think, can be extubated a lot earlier. They just don't want to do it because they're not comfortable doing it. They don't have people to back them up and stuff like that. So how do you take that variable out of your assessment?
Maybe I answer this. You brought a great point. That's actually one of the impetus for the study is that, during training in residency, we did a lot from backs, and a lot of times, as you said, anesthesia don't want to extubate the patient. The problem is that when you intubate them longer, it's even harder to extubate the next day. And then the edema, swelling goes up. And you mentioned cuff leak test, and that's actually a very unreliable way of measuring airway. Some people, they're ready to be extubated, but they don't have any cuff leak because, selection of the tube, if they have a small trachea, and the tube is relatively larger, you won't have as much of a cuff leak and whatnot. So, to answer your question, the anesthesiologist has a big role in when they get extubated. But I try to bring them a coffee in the morning, and I usually schedule these cases at the first start, and so we finish at the reasonable time, actually before their shift change. It's so there, and the purpose of this, I can tell them, well, in my experience, if we do it efficiently, not fast, but efficiently, all these patients do fine. Of course, if they have a valid concern, then we keep them intubated. But knowing that it actually may prolong intubation, it's a sort of self-fulfilling prophecy, in a way.
Maybe a follow-up question for you, Lee. Are there any patients with either, more radical sagittal corrections or other risk factors that you electively choose to keep intubated or would prefer stay intubated overnight?
It's a great question. I mean, we really try to keep the anterior and posterior surgical time short. I really tell the fellows and whatnot, probably an hour and a half is what we shoot for, even 4 or 5 levels. And then the posterior, we also try to keep it under 2 hours. Flip time is about, 30 minutes, 45 minutes in between. So I think if you do that, and then, also cervical spine, you don't have a lot of blood loss, so they're not fluid overloaded in general. They don't really require transfusion, so there's less edema. And then, post-op, keep them at the head of bed at 30 or 45 degrees to kind of even further reduce the edema. And, right now, I still keep all of them in the ICU to be closely monitored, but, in the future, we may be able to have them in the TCU instead. Yeah.
I think that was my question too, like Dr. Tay was saying, not looking at delayed extubation, but if you looked at the rate of reintubation as well.
Yeah, I actually don't recall any cases of reintubation for these patients. Some of these people, they go home on day 3. Obviously, it's not, the most common thing, but, some younger patients with rigid deformity, deformity is their main problem. They don't have any, other concurrent medical issues or frailty, because of the prolonged deformity, then they can do quite well.
The one main criticism of these databases is it tells you something, but it doesn't really tell you enough. And to make any decision on what we're doing, we just show that we're doing something. So, all these things, these disparities that we see, how do we know that that's actually a disparity of judgment versus a real disparity of access to care?
I think you bring up a great point, and the point of these studies is actually to show that we lack the data to perform the real studies and to actually distinguish if the disparities are real and what they are. And disparities are very dynamic. They change with time, they change with geography, they change with social influences, and with a number of other things. So the underlying point of this study, and I previously did another study looking at the pelvic Ewing sarcoma. And in 1999, Euro-Joving trial was started in Europe, and they showed that basically sacral Ewing sarcoma can be treated with radiation and surgery, its equivalent outcomes. But since then, in North America, there has not been a single pelvic Ewing sarcoma trial that has been done. The point of the paper was that we need to have better access to data and more universal or more like the only way to go forward is to have more collaboration in terms of research and not to create our own separate single entities. And you're absolutely right that these studies, that's what was the main limitation. They don't have competing analysis, and we don't even understand all the factors which contribute to these disparities. So my point of the study is to show that we definitely need more improvement in data collection and more collaboration.
All right. Well, let's welcome our next speaker to the podium, Dr. Greenstein, who will speak about single-level transforaminal interbody fusion and post-op lordosis.
Good morning. My name is Victoria Greenstein. I'm one of the fourth-year orthopedic surgery residents at the University of Arizona. Thank you for having me. I'm here to present a radiographic study looking at single-level TLIFs after 1 year. I have no pertinent disclosures for this talk or any other for that matter. So transforaminal lumbar interbody fusion is an excellent option for degenerative lumbar conditions because it allows for indirect decompression of the neural elements through distraction across the disc space while possibly restoring sagittal alignment. There's conflicting literature about the effect a TLIF can have on local sagittal balance. In fact, authors from UCSF showed that preoperative angulation at the disc space was one of the most significant factors in determining the change in lordosis after TLIF. However, there are numerous intraoperative factors that can contribute to sagittal correction, including implant selection, implant placement, and surgical technique. So this study, rather than using preoperative imaging, it looks at intraoperative imaging to determine if the amount of intraoperative segmental lordosis can be maintained after single-level TLIF after 1 year. To do this, we did a retrospective review of adults undergoing single-level TLIF for degenerative conditions from 2018 to 2021 with at least 1 year of follow-up. We measured the segmental lordosis using a Cobb angle at the fused level, and then the disc angle or intersegmental lordosis was measured via the Cobb angle from the superior and inferior end plates adjacent to the interbody cage. We repeated these measurements for the intraoperative imaging, and then at each subsequent follow-up at 6 weeks, 3 months, and 1 year. So who are our patients? Our average patient was in their mid-60s. 71% of our patients were female. Consistent with our population in Phoenix, Arizona, 43% of our patients were obese, with the average BMI being 30.6. Most of the patients had a primary surgical indication of spondylolisthesis, and the most common fusion level was at the L4-5 level. So how did these patients fare? This graph is looking at the average difference between the segmental and intersegmental angle measurements between intraoperative and postoperative imaging calculated at each time point. We can see that there was an increase in lordosis lost at each of the subsequent time points for both segmental and intersegmental lordosis measurements. Now, intraoperative imaging was conducted while the patient was prone compared to postoperative imaging that was done while the patient was in an upright weight-bearing position. So in order to try and determine if there was an effect, we also compared 6-week data to 3-month and 1-year postoperative data. At 6 weeks, we don't expect any sort of fusion at this point, and so we also saw that that trend continued for these patients, and that there was a statistically significant difference in the amount of lordosis lost between 6 weeks and 1 year for the intersegmental lordotic measurement. We also stratified this data based on the fusion level, and there was a loss of lordosis that was more pronounced at the cranial vertebrae of L3-4, but all fusion levels showed a loss of lordosis. In fact, the L5S1, so the most caudal segment, had the least amount of variability. So what does this data show us? It shows us that the amount of intraoperative lordosis was not maintained at 1 year postoperatively. This loss occurs at both the segmental and the intersegmental level, and it progresses from 6 weeks, 3 months to 1 year postoperatively compared to intraoperative imaging. There are several studies that show potential reasons for this. We did not explore those in this particular study, but the positional differences between prone and upright imaging, in addition to possible subsidence of the cage that has been well established in the literature. There's also adjacent level compensation that can contribute to whole lumbar lordosis and then global sagittal deformities. And then patient factors such as bone density, fusion rates, and then spinal pelvic parameters. Like all studies, this has limitations. This was a retrospective study with a relatively small sample size. We had 4 surgeons included in our analysis who are all orthopedic spine surgeons that had slightly variable practice patterns and patient populations. Like any radiographic study, the data that comes in can be variable quality, and we are limited based on the quality of the x-rays that we're using to make our measurements. And then there's some inter-observer variability in the manual measurements of Cobb angles. In the future, we hope to expand the study to include both regional and global changes in sagittal alignment, and then also correlate the data with clinical data such as VAS pain scores and then disability indices. Overall, there was a loss of both segmental lordosis and intersegmental lordosis at each level and at each time point after surgery. As surgeons, we always hope to leave the operating room with good sagittal alignment, but this study suggests that this alignment is not maintained in the postoperative period. Thank you.
Thanks very much, Dr. Greenstein. Our next speaker is Dr. Nathan, Association of Spinal Pelvic Parameters with Sacroiliac Joint Fusion Success.
Good morning, everybody. My name is Nathan Han. I'm one of the new spine fellows for Dr. Tan and Dr. Mooney this year. And today I'll be presenting on the topic of spinal pelvic parameters, its association with SI joint fusion success. I'd like to thank my senior authors, Dr. Ludwig and Dr. Sansor, who has been instrumental in providing the patient data, and my co-authors, especially Kevin Kim, who's a third-year resident, who would make any fellowship director proud. He's an excellent resident. No conflicts or disclosures. So sacroiliac joint dysfunction has been an underdiagnosed entity, which has been recently gaining a lot more attention lately. Approximately 30% of patients who present with low back pain in clinic was found to have an underlying diagnosis of SI joint dysfunction. However, there is no real objective metric to diagnose an SI joint dysfunction, as it's mainly a clinical diagnosis with provocative tests including Faber, distraction, compression, thigh thrust, and Gainsland tests with the goal diagnosis of an SI joint injection, providing at least 70% of pain relief. Now, if the patients are positive in 2 to 3 out of 5 of these provocative tests and their pain gets better with an injection, then they may be a candidate for an SI joint fusion. But as I mentioned, there's no objective data, especially any radiographic parameters that currently exist in both diagnosis and positive predictors of an SI joint fusion success. And in the past 5 years or so, however, there were studies that demonstrated that, especially in post-operative patients who had iatrogenic pelvic incidence or lumbar lordosis mismatch with an increase in pelvic tilt, these patients tended to have an increased higher incidence of having an SI joint pain that was diagnosed with the intra-articular injection. So our rationale was that patients who have higher pelvic tilt at baseline prior to the SI joint fusion success who present with the clinical symptoms of SI joint pain, maybe they're the candidates that may benefit from an SI joint fusion more and have a less failure rate than those who did not. And so that was our hypothesis leading to this study. So we did a single center retrospective analysis of patients who underwent an initial SI joint fusion, not a revision, of both MIS and open between the 2016 and 2022 with at least 100-day follow-up. And these patients were stratified into 2 groups, those requiring a revision fusion, those that did not require revision fusion later down the line. And the preoperative spinal pelvic parameters were collected on a standing X-ray. And the primary outcome was a need for revision SI joint fusion. Statistical analysis involved univariate and multivariate analysis. This is a summary of the patient characteristics and the different variables that we collected, both categorical and numerical, including age, sex, smoking status, BMI, preoperative fusion levels, number of levels, whether it included a pelvis, were there any gas in the SI joint, the different polyparameters, and the Russoli classification. Both including MIS and open, and about half of the 50% of the patients ended up requiring a revision fusion. So our stratification ended up being about 50-50, which really worked out well for our study. This is a table that stratified the two groups, and those that needing revision and those that did not. And interestingly, and in concurrence with the prior studies that looked at the incidence of postoperative SI joint pain, the patients who tended to have a higher pelvic incidence, lumbar lordosis pelvic incidence mismatch, and a pelvic tilt tended to have a better rate of the success of SI joint fusion, not requiring a revision. And multivariate analysis ended up having the pelvic incidence, higher pelvic incidence as the most statistically significant factor, reducing the odds ratio of requiring a revision fusion. So in terms of the discussion of the results, as I mentioned, a higher pelvic incidence, pelvic tilt, and the mismatch had lower revision rate, which from our rationale, the higher pelvic incidence allows a greater capacity of pelvic incidence lumbar lordosis mismatch to occur, creating a greater tension or stress placed on the SI joint when the pelvic tilt levels arise. As Dr. Greenstein mentioned, there's important to note that when we do lumbar surgeries, even segmental, we must be cognizant of the causation of iatrogenic loss of the mismatch, because those perhaps may be influencing the SI joint area as well. And another idea to throw out there is for patients who have severe deformity and severe mismatch, who are just unable to undergo large deformity surgeries due to their medical conditions or whatnot, perhaps if their main pain is low back pain with a potential for SI joint pain, minimally invasive SI joint fusion may be an alternative to at least partially alleviate their symptoms without having the patient to undergo large deformity surgeries. And that's it. Thank you for your attention.
Thank you very much, Dr. Nathan. Our next speaker is one of the graduating orthopedic spine fellows, Andrew Suarez, who will give us a talk on hip range of motion, predicting outcomes following spinal fusion surgery in adult deformity patients.
Good morning, everyone. My name is Andrew Suarez. I'm one of the graduating spine fellows from UCSF, and I'll be discussing hip range of motion, predicting outcomes following spinal fusion surgery in adult spinal deformity patients. I have no relevant financial or personal disclosures. And the hypothesis for the study was that hip range of motion could predict global and disease-specific patient-reported outcome scores following spinal fusion surgery. Activities of daily living in all patients pre and post spinal fusion include reaching the ground, tying their shoes, and perineal care. And these simple tasks might seem very simple to us, but it really leads to a lot of independence and positive outcomes in patients. And after spinal surgery, we know that patients lose spinal motion and rely on other joints to compensate. Some of these studies have shown that even one level of fusion can decrease total spinal motion from the L1 to the S1 segment about 14%, and the total motion at that one fused segment can decrease about 77%. So these are just two videos showing patients with the same fusion construct. And this patient on the left can only bend down and reach just past his knees, while this patient on the right here, again, same fusion construct, can really touch down all the way to the ground. And obviously there's a difference in preoperative hamstring length and hip range of motion as well as knee range of motion. So we used a 3D motion capture system with axial and appendicular markers set to the patient, and we measured this range of motion through a flexion and extension sit-to-stand cycle. The groups were divided into healthy control subjects, patients with back pain but no levels fused, patients with 1 to 3 levels fused, 4 to 8, and greater than 8 levels fused. And we measured radiographic data such as pelvic incidence, pelvic tilt, SVA, and patient-reported outcome measures, including EQ5D, numerical rating scale, and the Oswestry Disability Index. And the correlation coefficients were derived between the hip range of motion in the sagittal plane and the patient-reported outcome measures. And also a neural network algorithm was created to correlate and predict the hip range of motion with outcome scores. This is just images of different constructs that we use in the patients, from 0 levels of fusion all the way to greater than 8 segments of fusion. And in the total cohort, we had about 67 patients with an average age of 65 years, average follow-up greater than 2 years. And there was no difference in the sagittal alignment parameters in all the groups, with a mean PI-LL mismatch of 6 degrees. The patient-reported outcome score measures were as listed below, with the EQ5D average 0.5, ODI of 41, and the NRS score of 5, with significant differences in all groups. And obviously here at the end, the mean range of motion in the unfused groups was greater than those fused groups. All the data was collected and then graphed and tabulated, and then run through the correlation coefficients and the neural network algorithm prediction model. And we found that the hip range of motion during flexion extension was correlated moderately to the EQ5D with an R squared of 0.156 and the ODI with an R squared of 0.178 in those patients with greater than 4 levels fused. And then when we ran the neural network prediction model, it predicted the ODI outcomes in 87.5% correctly, with an area under receiver operating curve of 0.795 and about 70% prediction of the EQ5D with AUROC of 0.728. Sorry, there was a graph here, but it's not shown up here. But this is just showing the AUROC of the EQ5D and the ODI scores with good predictability of about 70 and 68% respectively. So in conclusion, hip range of motion can predict patient-reported outcome measures in the adult patients following spinal fusion surgery, and those with limited hip range of motion may benefit less than those with greater hip range of motion. You know, we know that even a few inches can make all the difference in the world in these patients if they could just bend just another inch or two to tie their shoes or just take care of themselves independently. So I want to thank Dr. Shane Birch for giving me the opportunity for this project, and UCSF for all the training I've received this past year. Thank you.
Thank you, Dr. Suarez. Our next speaker is Dr. Dada. Do patients with sexual dysfunction improve after lumbar surgery for grade 2 spondylolisthesis?
All right, good morning. I'd like to thank the organizers for inviting me to present my work, as well as my mentors, Dr. Praveen Mumaneni, the late Dr. Irene Say, and the QOD PIs for their mentorship on this project. Do patients with sexual dysfunction improve after lumbar surgery for grade 2 spondylolisthesis? So previous work from our group in the context of grade 1 spondylolisthesis found a high prevalence of sexual dysfunction at baseline with a prevalence of over 80%. And of those patients, we saw that a large majority of patients with grade 1 spondy tend to do pretty well in regards to sexual function after surgery, and 70% of those patients have improved function. In the current work, we wanted to see if similar trends of prevalence and prognosis remain for patients with grade 2 spondylolisthesis. We identified patients who were sexually active at baseline with complete 2-year follow-up in the prospectively collected QOD. And patient-reported outcomes included EQ5D, ODI, and VAS for leg pain and back pain. 400 patients in our grade 2 spondy database, 128 were sexually active with complete baseline and 2-year PRO data. The mean age of this cohort was 57, and 60% were female. At baseline, 80.5% had sex life impairment, and the intensity of their severity was pretty high, with a median rating of 4 out of 5 on the sexual impairment scale. At 2 years, 82.5 of those who were impaired had improved sex life, and they tended to have markedly improved function with a median of 1 out of 5 on the sexual dysfunction severity scale. When we compared those who improved to those who didn't gain any improvement, we didn't really see any baseline differences in regard to demographics and clinical variables. Surgical features of improved patients included higher rates of interbody use. We found that in those who had improved sexual function, 94.1% had interbody use compared to only 78% in those who did not get any improvements. Post-operatively, improved patients also had lower rates of 3-month readmissions and were more satisfied with their surgery. Interestingly, those who improved in sexual function also had improvements in VAS, leg pain and back pain, as well as ODI and EQ-5D. So it seemed that they responded very well to the surgery in multiple facets of their life. In conclusion, sexual dysfunction is present in over 80% of patients who present for lumbar surgery for grade 2 spondy. And a large majority of these patients improve with their sex lives following surgery. Thank you.
Thank you very much, Dr. Dada. Our last speaker for this session is Dr. Ambati. Do obese patients undergoing surgery for grade 1 spondylolisthesis have a worse outcome at 5 years? Follow-up, a QOD study.
Good morning, everyone. My name is Vardhan Ambati. I'm a fourth-year medical student at UCSF. I'd like to thank Dr. Tan and the conference organizers for the opportunity to present. And I worked on this study with Dr. Sam Zomer, Dr. Mumeni, and Dr. Tan's spine fellow who graduated this past June. And we'd like to thank Dr. Mumeni and the QOD PIs for their mentorship on this study, looking at outcomes 5 years after surgery for obese versus non-obese patients. So previous studies have not investigated the long-term effects of obesity on outcomes for grade 1 spondylolisthesis surgery. We compared patients with a BMI of 35 versus those who had a BMI of less than 35. We looked at demographic and preoperative characteristics. And then for the outcomes, we looked at patient-reported outcomes such as MCID for EQ-5D, ODI, VAS back and leg pain, as well as surgical outcomes such as reoperations and readmissions. So at baseline, the cohort with BMI greater than 35 had worse back pain, leg pain, quality of life, and EQ-5D. So the cohorts were not one-to-one. And at a 5-year follow-up, we had over 80% follow-up after 5 years for 608 patients. When we looked at the outcome following surgery, even though the cohorts, the obese cohort had worse baseline PROs, they achieved similar rates of MCID for VAS back pain, ODI, and EQ-5D. They did not achieve MCID for leg pain. They also had very similar rates of reoperation overall for original surgery. And not shown here, they had very similar rates of reoperation for adjacent segment disease, and they had similar rates of readmissions within 90 days following surgery. And importantly, both cohorts had equivalent satisfaction between for surgery on the NAS satisfaction scale. Our multivariate analysis corroborated these findings. We found that there were no significant differences between the two cohorts in achieving MCID for back pain, ODI, and EQ-5D, but there were differences based off of obesity for leg pain. So in our conclusion are that patients with a BMI greater than 35 did have worse pre-op and post-op outcomes. However, they do achieve very similar rates of MCID for back pain, quality of life, ODI, and they have very similar rates of satisfaction from surgery. So obese patients do benefit from surgery, our findings indicate that these improvements are attainable at 5 years, which is reassuring. Thank you very much.
So Andrew, really important observation about looking at preoperative hip motion, because so much of mobility is dependent on that. After deformity surgery, and you and Shane did a nice job of looking at that. I just wonder, I'm having trouble, your R values were 0.13, 0.15, and you were generously called that a moderate correlation. I would suggest that that's no correlation at all, yet your AUC was incredibly high. So how do you end up with a AUC with regard to a predictive model suggesting that hip motion predicts outcome with an area under the curve of, what, 0.85 you said? an R value of 0.15, that seems completely incongruent. And as I said on the first day of fellowship, it's okay to say I don't know.
Yeah, I mean, I would have to think about that more, to be quite honest. But I think that there's so much that goes into the outcomes and the EQ5D and the ODI that this is just such a small subset of it, just the hip range of motion itself. And I think that there is a distinction in that there's a discrepancy in that there's a high predictability, you're right, in the AUC, but then when we ran it through the correlation coefficient, it was only 0.15, but it was statistically significant, our findings, with a p-value of less than 0.05. So I would have to think about that and get back to you on that, to be quite honest, but I think that, yeah. I think it gives us a good framework because it just gives us a piece of the puzzle because, we as spine surgeons, I think we just think about the outcome of our surgery and just the parameters, and we think that that's going to give patients the significant relief that they need. But there's so many other pieces to the puzzle, and it just gives us another outlook and another avenue to do more research in and just to benefit patients and their outcomes.
This one's for Dr. Nathan. Where are you? Oh, there you are. It's a very intriguing data set that you have because, we're fed that from all the SI joint fusion studies that the fusion rate is very high, success rate is exceptionally high to the point that at which the insurance companies won't even let us do injections anymore on the SI joints. Your revision rate is like 50%. Yeah. So one question is, why do you think that's so high, and why were they revised? If they're revised for pseudarthrosis or loosening, hardware loosening, why was it so high compared to what is told to us from all the white papers on the clinical series on SI joint fusion? And number two, if they were revised for pain, if the patients had retroversion, then you would suspect that they lost lumbar lordosis and they have some kind of a potential sagittal plane deformity or at the end of their ability to compensate for sagittal plane deformity, which would then lead to back pain. So were they revised because of pain that was coming from somewhere else? And then when they were revised, did they actually get better?
Yeah, those are excellent questions. And I think those two questions are actually interrelated in one way. I think one of the main problems is doing SI joint fusion on the right patients. And I think that's one of the reasons why we may have had a much higher revision rate, because the patients ended up receiving a procedure that may not have been the problem-solving procedure for their pain. So I think what these spinal pelvic parameters, those things would assist is picking that right patient who may actually truly carry the diagnosis of SI joint pain that would benefit from that fusion. And I think people that have other etiologies of the back pain causing problem, obviously those patients would not benefit from any revision of the SI joint fusion. These patients will keep having recurrent pain, and many of those patients that require revisions, they require more than one revision. They had repeated procedures, which implies we're not solving the right problem. So I think it's important that in any pathology we have to know how we're going to diagnose the patients, and I think in SI joint dysfunction, I think that's still pretty unclear, and we need some more objective parameters in order to better diagnose.
So are you suggesting that the clinical exam, in addition to a diagnostic injection, is insufficient to diagnose SI joint pain?
Yes.
I don't know. Good question. Thank you very much. The other question I have was for, this is kind of a fun question, actually. Dr. Ambati? Oh, yeah. So, Dr. Ambati, so I love it that you guys get such great results with obese patients. And I would love to send you all the obese patients that I have in my practice above BMI of 35 and 40 to Dr. Mumaneni to have them take care of. Right? So this is the observation. Did those patients actually lose weight after they got operated on?
I don't have that information. That was
because
hard, yeah.
because a lot of people say I've got back pain, I can't exercise, I need something done to decrease my pain, to lose weight so I can exercise. So it'd be interesting to see if they actually lost weight.
Yeah, that's a great question. That information's not included in the QD database. We have pre-op weight, but I don't think we have follow-up weight, but that's a great question.
Before you send me all the BMIs of 50 people, what I'd like to say is that the data that he presented is from 14 sites. And a lot of those sites are, Midwest, South, East Coast. So I can tell you at UCSF, we tend not to avoid, we avoid surgery over BMI 35. Definitely avoid surgery over BMI over 38 or 40. And we will ask them to, do maneuvers to reduce their weight, and a good number will and some won't. And your hand is forced if they have a neurological deficit. You just have to, you're stuck with it. But we have had success now with some of these new weight loss drugs, and even with gastric sleeves and things, some people have lost quite a bit of weight.
One question for Abe before the break. So, the sexual dysfunction in lumbar pathology, it's probably not talked enough during clinic visits, and it's important. You showed like over 80% of patients have dysfunction. In your study in the database, did you collect when did people actually resume sexual activity? Because that's one question that often comes up, at follow-up, and patients ask you. So, do you have that data? If not, what do most people do here? How do you counsel the patient?
Yeah, so unfortunately, we don't have sort of time to return to sexual function data collected in our database, but in the data that I reported, we do inquire on the degree to which pain interferes with sexual function. So at least we can say from the data that I presented at 2 years after surgery, they were able to return to sexual activity. And I guess to add to your point about counseling, I think that this data shows that people who present with sexual function are likely to have benefits from surgery in regards to sexual function and also other aspects of their health.
Praveen, when do you let patients go back to having sex?
I think, after a month, I'd be okay with that. So I just want to make sure that the incision, everything is healed. We do sometimes, as physicians, not ask these questions. But I think for patients, it is a very big issue for them personally and for their satisfaction and their outcomes. So it's included in the ODI data set on one of the versions of the ODI. That's how we got this data. We got it from the ODI at 14 sites. So, for patients who have that issue, it can be brought up, and you can advise them that if they have surgery, they are likely to benefit with their sexual function.